I'm Peter Schwartz. I'm the director of the IU Center for Bioethics, and it's my pleasure to be here today to welcome you to the IU Bioethics Grand Rounds. We have people online and a nice collection here in the room. Hope we're all enjoying our donuts and coffee, a new feature that I think is a success because it's good. So we're honored to have Dr. Ellen Wright Clayton as our speaker. Professor Clayton is, and I'm going to have to read these titles. There are a few. She's the Craig Weaver Chair in Pediatrics, as well as Professor of Law and Professor of Health Policy at Vanderbilt University. She's one of the leading researchers and experts in the country and really in the world on ethics and genetics, looking both at research and at implementation of genetic medicine. She's led multiple NIH-funded studies and centers in that area. Dr. Clayton has written 2 books and over 200 research articles. She's worked on or led numerous projects for the National Academies of Medicine and Science, including serving as a member of the Advisory Council and as chair of the board on population health and public health practice. She's currently co-chair of the Reports Review Committee of the National Academy of Sciences, Engineering, and Medicine. And she's an elected fellow of the American Academy for the Advancement of Science. Most importantly, she mentored our own Dr. Colin Hamilton, and then as a postdoc over at Vanderbilt, and then sent him over to us, perfectly trained to lead our work on genetics and ethics and do the collaboration, the excellent work he's been doing here. So her background and position and her connection to our center through Dr. Harrison made her a natural speaker on today's topic and for today's Grand Rounds. Today she'll speak to us on whole genome sequencing in newborns and young children, and I'm looking forward to learning from her along with the rest. Thank you.
Well, thank you so much, Peter. It's a real pleasure to be here. I was saying the only other time I'd been in Indianapolis, I'd been diverted on an airplane and just sat at the airport. So now I am absolutely thrilled to be here and see what an amazing community this is. So it's just a real pleasure. I'm not planning to speak for the whole hour, so I'm really going to be ready to take some of your questions or comments or to facilitate discussion. So with that in mind, why don't we go ahead and get started? So I want to say something about conflict of interest and about my background. First of all, I have no financial conflict of interest in this area. And frankly, I don't think any intellectual conflict of interest. I have, however, been a member of Tennessee's Advisory Committee on Genetics since 1991. I served on the American Academy of Pediatrics Newborn Screening Task Force around the turn of the last century. I have been involved in studies on newborn screening for cystic fibrosis, ethical screening on ethical decision-making for newborn screening at the Hastings Center, as well as numerous projects on pediatric ethics. And as Peter said, I have been doing work on genetics and ethics basically since 1978. So I have long standing here. And I've written a lot of articles about pediatric genetic testing, which I'll allude to probably. I cannot start a talk about newborn screening without talking about Gattaca. Now, I realize that some of you aren't even old enough to have seen Gattaca, but I want to start with it in no small part because this was a movie that came out in 1997. At that time, I was on the advisory council for the then National Center for Human Genome Research. It wasn't even an institute then. And I remember that Francis Collins was furious about this movie. And so you'll see in a minute probably why. But I actually think that there are some things that happened in this movie that are really salient for our discussion. So you see the top is Ethan Hawke, is the lead actor there, and Uma Thurman on the bottom. And it starts, and I'm going to just click through this because it turns out that audio doesn't work well. But it starts, well, it actually starts by saying, I was conceived on the Riviera, and it's in the back of a Riviera car, which is an old model Buick, which some of you don't recognize either. And this is our hero at birth. and he has newborn screening. And it looks like, I guess and the doctor who was doing this took a sample of blood, put it in a tube, and very seriously said, 10 fingers, 10 toes, that's all that used to matter. But now my immediate well-being was not the sole concern. My destiny was mapped out. What's in red was in the original script that was taken out before it was actually taken. All my flaws, predispositions, and susceptibility, most untreatable to this day, only minutes old, the date and cause of my death was already known. Heart disorder, 99%, there were many other things, and his life expectancy was 33 years. So the whole point of this movie is that these predictions were wrong. It turns out that Ethan Hawke was made a maintenance worker, but he actually got somebody else's DNA, Jude Law, not bad DNA to get. And he managed to pass his Jude Law. He actually had a cardiac stress test, which he didn't die, so that was a good thing. He also won the love of Uma Thurman, also not a bad thing. And he ultimately ends up going on a rocket ship to a moon of Jupiter. And that, I have to say, why does anybody want to do that? But whatever. And the tagline for this movie is, there's no gene for the spirit, basically. So the message is that this is not going to predict the future. So, and this is, I think, what made people angry or upset about it. But in point of fact, some of the concerns that we talk about, worried about being discrimination, so problems that we still haven't resolved, predictions that turn out not to be completely accurate, that still is a problem. All of that, I think, is very much in play. So I think we really have to talk about this kind of screening. And then I would just notice that Francis Collins, in 2010, in his book, The Language of Life, said that he was almost certain that complete new genome screening will become part of newborn screening in the next few years. So, I mean, so this is what we're facing here. So our options for screening have expanded over time. Certainly, we are in the process continuing to think about state-run newborn screening. It's interesting to think that this was an accident of history, that screening for PKU, which was the first thing we looked for, was initially that the AAP was not very excited about it because it wasn't clear how you treated PKU. Advocacy got the state of Massachusetts to start screening for PKU. Since that time, it's actually expanded very widely. It's now in all 50 states, all of our territories, in most countries around the world. And once you are doing a test on one thing, you can do tests for other things. So that's why we've ended up where we are now. A major advantage of state-run newborn screening is justice. And the reason that I say that is that at least in terms of access to screening, everybody gets it. And we all know that many parts of our healthcare system, there are things that we ought to be getting that many people don't get because they don't have access to healthcare or because they don't have adequate insurance, other things like that. So I'm certainly going to talk more about state-run newborn screening, but it is interesting. It is the only state-run health-related genetic testing that we do in this country. The other big genetic testing that we do in this country is for purposes of forensics, for purposes of the criminal justice system. In addition, we have increasing use in clinical diagnosis. I'm going to talk a little bit about this, but it has become very important. And then obviously we're going to talk about the growth of direct-to-consumer genetic testing. As many of you may know, more than 100 million people in the world have had direct-to-consumer genetic testing. The overwhelming majority of it is for ancestry, but some of it is for health-related issues. The future of this is a little uncertain given the straits that 23andMe are in the present. But one point that I want to make now is we act like direct-to-consumer genetic testing is brand new. And you know what? It's not. It's not. Because I have a study that was down here, published in 1997, where Dorothy Wirtz actually surveyed a whole bunch of genetic testing labs and found out that 45% of them had pursued testing even if a physician hadn't ordered it. Now, admittedly, this isn't as common as what we see now, but nonetheless, this is not new news. This is a theme that I'm going to go through here, that a lot of what we're talking about here is stuff that we've been addressing for some period, just in a new package. So where are we now? It is now possible economically to do genome-wide screening or even whole genome sequencing. There are clearly settings in which tests have clinical value in diagnosing symptomatic children. The poster child for this is critically ill newborns, and this is Kingsmore's work, but adopted around many parts of the country. There is some debate about what constitutes critically ill newborn that justifies the treating. And that the other issue that people talk a lot about is what the justification is. And the justification usually is to talk about change in management. In some cases, that you can actually do something therapeutic that's going to improve the child's outcome. In other cases, the results lead to other changes in management, including backing off on totally aggressive care. And the other big group that we talk about doing whole genome sequencing on are children with undiagnosed developmental delay. These are kids, both these groups I'm talking about are kids who are already symptomatic. And the issue with undiagnosed developmental delay is in part because sometimes there's something we can do. Most often, it's to get a diagnosis and to refine a prognosis. So that's not what I'm going to focus on today. I'm willing to take questions about it later, but that's not what I want to focus on right this minute. And the big issue with all of this is access. Because if you are born at IU, or if you're born at Vanderbilt, or if you're born at University of California, San Diego, which is where Kingsmore is these days, you can get these tests done. I mean, and particularly for the critically ill newborns, sometimes within a matter of 12 hours. But if you are not at a place like this, then that becomes a good bit harder to do. And you may not get these results in a timely fashion. It may take several days, weeks, more than that. The issues with the kids with undiagnosed developmental delay, the big issue there is who's going to pay, because many Medicaid systems don't. And almost half of children in the United States are covered by Medicaid. So, so there are real issues of access and justice and what you're going to do about that. So I think some of the most perplexing issues, I shouldn't say most perplexing questions, some of the most perplexing questions regard using whole genome sequencing on asymptomatic children. This is inherently screening. And I want to say something about screening as a general pediatrician, which is that we screen all the time in medicine. When we see kids, we see if they're growing appropriately, we see if they're developing appropriately. When people become adults, when you get to be 40 or 50 years old and a woman, there's some debate about what the right cutoff is, but you get to get a mammogram. And if you go a little bit later than that, you get to think about whether you're going to get colonoscopy or some other intervention. But we do a lot of screening in medicine, and we time the screening for when we need to do something about it. In general, that was what the criteria was for newborn screening, that the idea was that you needed to find something that you needed to diagnose and start treatment before symptoms occurred in order to avoid in order to avoid long-term problems. Some of the factors that we think about when we think about screening include what the prior probability of the disorder is. If something is really rare, then it's more likely that the result you get will be a false positive. There are characteristics of the test, both in terms of sensitivity. Are you going to find the kids who are affected? Are you going to specificity? Are you going to exclude the kids who aren't? Again, there are issues of false positives here, which include, as a practical matter from the perspective of the child and the family, getting a diagnosis that's never going to make the child sick, which not everything is fully penetrant. And here we're just talking about single gene disorders or whether there are false negatives. The values and consequences of making a diagnosis, can you do something about it? And can you do something about it that you can afford and that you can get access to and that is not too onerous for the family? And of course, as I said earlier, at what point do you need to be doing when do you need the results? When are they needed for care? And so, because screening occurs throughout the life course, I mean, it turns out that the one virtue of doing it in newborns is they can't get away. And so, and people fall out of healthcare in our broken healthcare system. But nonetheless, those are some of the issues that we need to be talking about. There are a lot of stakeholders in this space. And I've divided this into who decides, who's across the top, and then who is affected. We talk about the role of parents. This is a vexed issue in our culture about what rights parents do and do not have to make healthcare decisions for their children. And highly contested these days, as we've seen in the context, for instance, of transgender care, where parents are not allowed to decide that that's the healthcare that their child needs, and other things of that nature. Healthcare providers have something to say. Professional organizations, by the way, set the standard of care. I mean, and they rely primarily on evidence about what works and what doesn't. Now, every single decision that both healthcare providers make and that professional organizations make also involve ethical issues. There is no simple scientific answer to any of these questions. And then importantly, the payers have an enormous impact here. And as we see increasingly expensive interventions, as we are seeing both with regard to obesity and Ozempic, and then also with thinking about gene therapy, there are just some payers who won't pay for this. And they will say that it's because it's either too expensive or the data aren't clear enough. The UK has decided not to pay for gene therapy for spinal muscular atrophy. They are very much involved in this. And frankly, if your payer can't pay for it or won't pay for it, you just have a problem. And then we also have questions about the roles of legislators and regulators who increasingly are getting into this space and deciding what it is that all of these people can do. So many, many stakeholders in a way that we really didn't think about before. And in terms of who's affected, of course, the child is affected. The child is the only one who doesn't have a voice in this. Impact on the family, I'm going to say a little bit about that in just a minute, but clearly making these diagnoses may have an impact on the family. And we can even talk about, as I will in a minute, that the American College of Medical Genetics a number of years ago suggested that we ought to be screening children for high impact oncology genes like BRCA and some of the colorectal cancer genes. And we ought to do that, not because the kid needs anything right away, but because it affects the family. I'm going to come back to that in a minute because I have a critique of that. The healthcare system cares, and of course, society cares. So this is a very complicated calculus, that we need to be thinking about. So let's talk a little bit more about state-run newborn screening. And to begin to say, that it was very slow initially. It started in the late 1960s in Massachusetts with PKU. It was another decade before it was common to think about adding hypothyroidism, which of course is not specifically genetic per se, but it was something that made a lot of difference. It was cheap to test for and really effective to treat. So things got added slowly over time. The American College of Medical Genetics got in the game in 2005 in defining a set of disorders that they thought ought to be screened for. There was some criticism about the process by which they did that, but nonetheless, it was what was going on. And then subsequently, we've had a number of federal advisory panels that have varying mandates. But throughout this, parents have been incredibly effective advocates. They were part of the reason that we started doing state-run newborn screening for PKU in Massachusetts. They were part of the reason that it spread across the country. I've been on our advisory committee. There are a lot of disorders that don't even meet the federal advisory panel that nonetheless get added to newborn screening panels because of parental advocacy. But these are parents whose children are affected. And so they are having a very, very prominent role in how these programs are developed. If sequencing is done, and as we think about doing whole genome sequencing on asymptomatic children, what variants should be looking for? Now, I have to begin to say that many, many of our tests in medicine are multiplex. They can look for a number of things. And so if you order a CBC, your lab, if you want to order a hematocrit, for example, your lab almost surely will do a CBC and just won't report the other stuff out. The major technology that we currently use in newborn screening is tandem mass spectrometry, and it allowed us to add 45 or 50 new disorders. But the important thing to realize is that that technology could actually have detected hundreds of disorders. Decisions were made about which ones were detected and which ones weren't. So just because you can do something doesn't mean that you have to do something. And then we have to talk about what the criteria are about defining what's going to be added or not. And certainly in the early days of newborn screening, with the Wilson and Younger criteria, our view was that we ought to be doing tests that are acceptable to the public, that we can understand, that we have something effective to do, that we have to start something right away. And so the early disorders included things like PKU, hypothyroidism, galactosemia, membranous urine disease, things that you really need to start therapy for within the first few days of life. Increasingly, we're expanding beyond that. And so so that's an issue. And then one question that I think that I'm going to come back to at the end is it necessary or even desirable to do the whole genome? The cases of using these in the critically ill neonates or in the children with undiagnosed developmental delay, where you don't have a prior hypothesis about what the disorder is, in those cases, you do have to look at the whole genome in order to see if you get a clue about what's going on. But often when you're doing tests, you don't need to look at the whole genome. You just need to look at the disorders that you actually have in mind. And so many companies have seizure panels and rheumatology panels, things of that nature, arrhythmia panels. And there is an ongoing debate that I'm going to return to in just a minute about what to do about findings that you weren't looking for. Now, I have to say something here about language because I care about this. I'm a lawyer, so I care about this intensely. Words matter. Early on in this debate, there were a lot of discussion about, well, what about incidental findings that you just happen across? Now, those do happen in genetics, and this came full force from the language of imaging. because when you look at a chest x-ray, and suppose you're looking for a pneumonia, and instead what you find is cardiomegaly, or what you find is a ditzel that looks like cancer. That's an incidental finding because it's right there on the screen. Radiologists look at that all the time. Incidental findings can kill you. It killed my mother. And I'm going to tell you why. My mother had 150 pack year history of smoking. And she was living near me. She moved near me so that I could help with her medical care. And she slipped in the bathroom and hurt her ribs. And so she wanted to go to get a chest x-ray to see if she'd broken her ribs. Well, she had so much osteopenia that you couldn't even tell, but there was a little ditzel there that looked like lung cancer. Now, my mother thought, and so that was an incidental finding. I mean, literally incidental. We were looking for one thing, saw another. She gave up at that point. She said, I've, smoked like crazy. I don't want to go through surgery. I don't want to I just don't want any of that. So she just stopped. And she went into hospice care and she died. So, and it turned out that her, whatever that was, didn't even grow very much. But I just want to tell the point that incidental findings are not benign. Just saying. Other things you can talk about, the other language I think that's better to talk about are secondary findings, are unsolicited findings. Those are things because often, and this is what the American College of Medical Genetics did, was they said that if you are in the clinic and if you are getting a whole genome test or a whole exome test to look for undiagnosed developmental disability, by the way, you have to look at 57 other things, including BRCA, hemochromatosis, a bunch of other things. And they said that, and their initial thought was that everybody, if you had those tests, whole genomes or whole exomes, you had to look at every other thing. You just had to. And that, and I'm going to say a little bit more about that in just a minute, but they're just, and you had to do this even in kids, because even though kids, by and large, are not going to get breast cancer when they're young, or colorectal cancer, unless they have APC or something. So I have to say the genetics community rose up and said, no, we don't have to do this. But the idea that if you're looking for one thing, and that while you're there, that you have to look at the whole thing, was something that the college initially wanted to do. They backed off. And so we have to continue to ask the question, are there more focused technologies that we can use that would actually get us the answer that we want without necessarily getting secondary findings? So in these next two, and there was growing pushback for newborn screening programs. You all know that. You're in Indiana. You had parents who were fighting against newborn screening because Twyla Brace came, and because they didn't want the government to have access to their child's DNA. And so, and we've seen this in Minnesota, we've seen this in Texas. We're seeing it right now in Michigan. I think, as many of you know, Michigan did a really exquisite examination or community engagement about creating a population-based biobank. I mean, you may not remember, this was about 10 or 15 years ago, based on newborn screening samples. And part of that was to facilitate research. Part of it was to facilitate identification of children who went missing. And so they went through this whole effort, put it in place, called BioTrust. And now there's litigation going on in Michigan where parents are saying, no, we don't want BioTrust. You can't keep these data. So, in a society now where we are seeing so much distrust of state governments, so much distrust of the healthcare system, we are seeing serious distrust of what's going on in state-run newborn screening. So I want to tell you about the color coding of this in the slides that follow. These are some slides I made in 2008. Now, I have to say I amended them a little bit, and I'll tell you how. But, but they address what the arguments are for screening. Avoiding the diagnostic odyssey. This was the major argument for doing newborn screening for cystic fibrosis. And for early intervention, better support for families. They argue that families want information about their children's health. I have to add a little fillip here, which is that there was a study done in Boston where they offered whole genome sequencing to parents of kids in the NICU and parents of healthy children. And what they found was that the parents of kids in the NICU, some of them decided they wanted that. Some of them did. But what was really startling was that when they offered it to parents of healthy children, the vast majority of them didn't want it. So one of the things I think in ethics, I've been writing a little bit about this recently, one of the things we have to think about in ethics, what is it that people actually do? And what do they actually want? So nonetheless, that was there. Talking about reproductive planning, I mean, y'all live in Indiana, I live in Tennessee. This is vexed at the moment. So I'm happy to take questions about it. The last one, Claude Laberge, who is a geneticist in Canada, said we ought to do all this screening so we can learn more about these diseases. I mean, that's sort of an interesting thing to do, but thinking about research ethics and how you get going with that. Here are some reasons to be concerned about screening. People worried that parents would treat their kids differently. And identification of some kids who won't have symptoms. This is a tremendous issue that particularly we've run into with some of the lysosomal storage diseases and some of the others. Issues of incidental findings. I want to add this is an added slide as well. What essentially the American College of Medical Genetics did when it said that we have to test kids was it made the kids a canary in a coal mine. That basically, because adults don't get screened and they don't have whole genome sequencing, what you do is that you test the kids so that everybody else in the family will know. Now, I have to tell you that, and whether this is good or not for kids is an open question. We wrote an article about this in the American Journal of Bioethics many years ago with 3 people who said, we don't like this, 3 people who said they did like it. But one of the things that I've reviewed recently is what do people actually tell their families about the genetic test results that they get? And the idea that we're going to tell all of our at-risk relatives is just not accurate. It isn't what people do. I'm seeing some head nodding in here. I suspect there are some counselors in here, and it makes people crazy when they don't do that. And we do translational work in genomics at Vanderbilt, and we really find that people don't tell their relatives. And what we do find, and so I think I have a hypothesis that I haven't tested, that the people who come in to the geneticists because they are concerned about something, whether it's cancer genetics, whether it's something going on with their kids, the people who are motivated enough to get there, those are the people who are more likely to tell their relatives. People who just get the information for whatever reason may be less likely to do so. Certainly, I don't believe that correlation equals causation, but it certainly is the pattern that I seem to see. It's also interesting because parents say that they want to know about the adult onset disorders their kids have, which is interesting because a lot of adults who are at risk don't want to know themselves. So, so if they were making the decision for the self, they might avoid it, but nonetheless, the decision's been made for them. So I'm going to go back for just a second to make a couple of, actually, I think this is fine. So, the fact of the matter is, this is complicated. And thinking that the kind of family outreach, the kind of snowball sampling, which is the most effective way to think about using genetic testing, is something that doesn't always happen. And we need to be thinking about how we count that in our economic evaluations here. Increasingly pressing questions are who decides about the testing? And we have long-standing questions about the scope of parental decision making for their children. And it gets more and more vexed over time as we see what's going on in the legislatures now that are both on the one hand saying that they really want parents to have authority over their children, at the same time that they take it away. So I think this is a major issue going forward. Do or should parents have access to their kids' genomic data? If you do whole genome sequencing, under 21st Century Cures Act, I mean, I think we all fight about this, the lawyers do, but the fact is they probably can get access to the raw data, and you need to think about what they're going to do with the raw data, not that you can prevent it, but at least you can counsel them about it. They can share the data in other ways as well. They can put it on the internet if they want to, or they could actually send it to a third party that's going to reinterpret the data in a way that may or may not be, that may be misinterpreted. So are we ready for whole genome sequencing? I think the answer for that is emphatically no, particularly for asymptomatic people. It's clear that primary care providers are not ready. And I would just note here that this is work that Dr. Halverson did when he was working with me at Vanderbilt. We had a study where we were returning genetic results on variants in something like 100 different genes. And we thought we were going to do it through primary care providers because we can do decision support, a variety of other things like that. And what we found was that they hated it. They hated it. I mean, some of them did. Some of them thought it was fine. What they mostly did was that they referred it to the relevant subspecialist. And so, which is where we would have ended up anyway. And that some of them actually did the work themselves. And some of them called me up on the phone and they said, I hate you. I don't want this. Because these are not tests they ordered. These are things that we did in the course of research. One of the things we have to do in translational work and research is we have to introduce tests in a clinical setting where we can look at the impact and see whether it improves health outcomes. That's what we're supposed to do. That's what your CTSIs are supposed to do. I mean, that's it. But the fact of the matter is, if it's not somebody who's already the person's care provider, it's hard to know where the data are going to end up or who's going to be responsible for it. Turns out that that's hard. And so we've learned another lesson about that I was sharing earlier today. We are currently in another study we're doing, returning polygenic risk scores. And so for a number of disorders, for a number of things like breast cancer, cardiovascular disease, the things you would think about. But one of the things we found was that if we found somebody to have a polygenic risk score that indicated, for instance, breast cancer, their payer wouldn't pay for it. Why? Because we were generating the evidence that they wanted. They said, we're not going to pay for this because there's not an evidence base for it. And so what we found ourselves doing was that we now, as part of our grant funding, have funding set aside so that we can pay for at least the initial workup, a mammogram or a breast MRI or whatever. And so, so in a world where on the one hand, we care about data, as we should care about data, although there's a case pending in front of the Supreme Court right now that may change that, but we have to generate the data. And if we're going to generate the data, we have to be able to take care of the participants who we're involved with. So, I mean, we learned this. We are learning this painfully, one step at a time. And so, so there you go. And then the other thing that I have to say is that a major issue is the access to the extremely expensive therapies is going to be limited. We have 6 kids a year in Tennessee born with SMA. So, and most of those 6 are, at least half of those 6 are likely to be on Medicaid, because half the kids in Tennessee are on Medicaid. And so how are we going to pay for some of those enormously expensive therapies? If any of you read The Atlantic, there was an article a couple of weeks ago where a faculty member at University of Southern California had a child diagnosed with Duchenne muscular dystrophy. And she wrote an article about how she managed to get USC to pay for the $4.2 million it cost to treat him for Duchenne muscular dystrophy. I mean, so as we are moving into this era where we are finding things that we can't pay for, we have some real ethical dilemmas there about what we're going to do. I am not saying that we shouldn't necessarily be testing for this, but we have to be cognizant of what it is that we're telling our families, and and what it is that these results may mean for them. So looking back, so I think this is my last slide. Let me make sure. Oh no. So here are some closing thoughts. One is, why do whole genome sequencing if something else will work? I mean, why do a genomic test for PKU when you can actually discover it by looking at levels of phenylalanine? And it's much more specific for this. There are a bunch of genes that are involved in PKU. I mean, why do a genotypic test if a phenotypic test will do? I'm not saying that that's true in all cases, but it's a question that we need to ask. The major issues are we need to examine the impact of testing, the availability and if applicable of therapy. Some of these things don't have treatment. And what it means is that we'll decide that the decisions will be made about how to manage the child. And who gets to decide what tests to do? Because this is a very complicated ecology. And decisions that are made in the state newborn screening systems are not necessarily the tests that would be made in the professional societies. And certainly, they bear little relationship to what the payers are going to pay for. Not one of these issues is new. The only issue that's new are that it's much more available, and the treatments that we're talking about now are much more expensive, and we just have to figure out what to do. But there are lessons to be learned here, because we are not riding on a clean slate. And we do need to be talking about acceptability to the public, talking with our legislators, and getting done, and also taking into account that there is enormous pushback going on in this country about the state having access to data. And you all prevailed in that one, I think, but this is something we see increasingly and something you need to keep in mind. It's not what we can do, but what we should do. And all I can say is that this is a really complex issue, and we sure aren't ready. So thank you very much. They're actually, okay, yeah.
I'm curious with state whole genome sequencing and testing, is it a one-time interpretation or is it something that's going to be revisited after a time period? Because I just wonder, it seems like we're going to generate a lot more knowledge. So we might see a lot of variant of uncertain significances that we call that. And then 5 years down the road, they might be known.
That's a great question. I'm absolutely delighted you brought that up. One of the biggest debates that's going on now in genetics is this sort of duty to reinterpret. And one of the things that we're seeing is the labs are getting in the business of reinterpreting. They're sending results back all the time. My friends who are cancer oncologists say they get new reinterpretations. This raises a number of really important issues that I want to talk about, which is that, first of all, do you still have access to the patient? I mean, people move. And how long do you have to do that? There are suggestions that maybe you need to keep them for a really long time. At the same time, I have to say that if I had had a genome done a decade ago, and I had something now that I needed genetic information, the chance that I would rely on a decade-old genome is zero. Zero. I mean, a new genome costs less than an MRI, for crying out loud. So I would think that, first of all, this idea that you're sort of one and done, I mean, there's a lot of discussion about you get your genome done and then you don't have to think about it anymore because your genome doesn't change. Well, first of all, it does change a bit. But more important, the technology changes a lot. So, the thing that I think we ought to be doing, and there's a thing on the chat that I want to get to, but the thing we ought to be doing is telling people what we're going to do. That when we do the test, that if we get results back, we will try to find them. They have an obligation to keep in touch with us so that we can follow it. A lot of debate about whether you can share this information with the family if the patient has since died, which happens sometimes. I think this will all be shaken out, but the idea that you see a patient one time and then you owe an obligation of care into perpetuity is a little scary, actually. So I'm absolutely delighted that you said that. If you go back and if you look and you find something, and particularly, happily, most of them they go from VUS to more likely benign than pathogenic. But if you find something, then you're going to make a good effort. What we do in our studies is if we can't find them, we send a certified letter to show that we've made, as good an effort as we can make. But it's a really interesting problem. And, and one I think that we're going to face, let me just expand a little bit beyond genetics. As we get to the kinds of analytic tools that we have where you can actually analyze the whole medical record, then I think we will also have some obligation to think about following up when we do an analysis of a patient's medical record and think, oh, gee, they had something that I missed a while ago, and do I have to follow it up with that? I think that's a real issue, and one that I think, I don't practice clinical medicine anymore, but for those of you who do, these are things, the best thing you can do is address it at the front end. The very best thing you can do. There are a couple from the chat. Oh, God, you guys can see the chat. I think if you're in the NICU and they want all the information, I think the issue there is that you do it, but I think you need to counsel them about they're likely to find stuff that they may not want to know. And I think that if you have the possibility of the NICU of doing a more limited test or a more focused test to find what it is that you want to know, then I think that that would be an ethically appropriate option to offer. But being a parent's all about guilt. How about that?
Thank you. So that's fascinating talk. Thank you. On the question of who pays for it, right, which is obviously a big thing, as you pointed out, do you think a system similar to what I think exists for vaccines, where there's a pool of money, and if somebody has a really bad reaction to a vaccine that has severe effects, there's a pool of money that can help them cover the cost for that. in a scenario like this where whoever decides to get sequencing or testing for a specific, and it doesn't have to be whole genome, but specific tests, a few dollars from every one of those tests goes into a pool, and then those who have been tested, if they now realize they have one of these diseases or one of these variants that they're going to have a really expensive test, they can tap into that pool. Those who didn't obviously get tested, didn't contribute to it, wouldn't have access. Would that, something like that work?
I have a hard time imagining how much money you'd have to add. But you're right, that what the issue, you're talking about the National Vaccine Injury Compensation Program. And which was put in place in part because manufacturers stopped making vaccines because there was so much litigation about it. And so it's actually been incredibly effective to take care of the vaccine-associated injuries. Again, it's based on an evidence about what you know about what vaccines cause and what they don't cause. So the surcharge, sorry, I lost the word there for a minute, is like $3 or $4. I mean, I think it might have to be larger than that, but it's, but I think it's a real, that's a possibility. That's a possibility. I mean, you know, insurance is supposed to cover primarily catastrophic illnesses, but that isn't sort of how we do it.
I'm going to continue with the one in the room, one on the board. So we have a chat from Mary Ciccarelli asking, could you extrapolate just a little on the issue of whole exome sequencing in children with developmental delay, much of the same issues and whether we're ready for parents to know everything?
Well, I think I think they're exactly the same issues. I think that the issue there is that, and the way it works there is that the people who are doing those tests are also, I think, capable of interpreting them. I think that's a major thing, as in fact are the NICU people. But I think they need to know what it is, you know, what it is that they are, you know, what they're getting into before they undergo it. Getting a diagnosis is worth a lot for a lot of parents. And that, and the reason that you would do something like a test like this is the value to them of getting a diagnosis, not that there's often something that you can do about it. But again, it's a different deal when you're talking about symptomatic kids as opposed to doing asymptomatic screening of patients of any kind. That really is a different ethical discourse that really has to talk about a much more exquisite balance of the benefits and risk of proceeding with that. But I certainly agree with you about that. And I know I'm going to get asked a question about the NICU. So
yeah, I have a question. So what do you think we need to do to get ready? Be it general public, providers, parents, and then what is the obligation of the IUs, the Vanderbilts, the Rady's to provide that preparation, given what those institutions are doing?
Well, certainly, I think we need to be, you know, the idea that there are enough geneticists in the world to take care of this is just silly. It's just silly. I mean, and in every sense of the word, silly. So I think we need, first of all, to educate all kinds of practitioners about this. And we need to educate them. And frankly, I think that the PCPs, because what they do is screen, that's what they do, at least have got the screen stuff down. They've got those ethical issues down. And so the question is, you know, how do you get them the tools that they can use in real time that are going to help them do the tests? I think that it makes a lot of sense for someone who you suspect has I'm going to step out of the NICU for a minute, but who has a arrhythmia predisposing gene, a variant of arrhythmia predisposing gene. You ought to send those to the cardiologists who know how to take care of that and know how to interpret those data and not do that in a primary care setting. So I would say that that we ought to continue for our healthy kids with the panels that we're currently doing in state-run newborn screening, you know, plus some, and I know there There's a version going on now that's doing 200 or 400 or something, but not do whole exomes and whole genomes in otherwise healthy newborns. I think that we're not going to do that, and it would not make sense to do that.
One question.
And then I think we need to, think more specifically about how we educate our providers and the public about, what the public mostly thinks about and what private providers mostly think about are highly penetrant single gene disorders. That's what they mostly think about. And the fact of the matter is we're moving into an era now where we are going to be doing combinations of genomes and large understanding of environment and doing that together. That's going to take some really sophisticated tools that involve, for instance, AI, among other things, to help us understand those interactions critically, but also with a lot of signposts about where things can go wrong, because they certainly can. And so I think it's really going to change. It's going to change what we do. I still think we ought to test for things at the time when we need to do something about it or when we need to know about it. But this is going to change. I was going to say it's not going to change everything. It's going to change a lot. I'm afraid that's not a specific enough answer for you. But I do think that institutions like Rady, like Vanderbilt, like these others, are really going to have to think hard. Genetics is not self-executing. You don't get a genome and then you know what to do. You have to have a whole system in place that helps you translate it, get it to the patient, figure out how to provide care. All of that has to be put in place. And we are just beginning to do that, I think.
Well, one more question, but it's unusual for you. We really have to be out of the room too. This is a deep PhD defense here. So,
oh goodness.
A quick question, what 2-sentence answer, Alex? I know impossible, but.
Yeah, just going with that, I think kind of your point of translation and how do we, take all this information that we have on symptomatic patients, on our more severe cases, and translate it into someone who's pre-symptomatic and trying to help family understand a gene or a diagnosis when their child doesn't have any symptoms, and we don't know what that might look like in 5 years, 10 years, because we haven't been testing individuals without symptoms for very long. And so I think that's something I struggle with personally. I don't know if that's something that you've encountered or have addressed before.
I have to say that it makes me really nervous to look for things in people who are not currently symptomatic. And it makes me think that it's going to require all the empathy. I know that's a buzzword here, so I'm going to use it. It's going to require all the empathy and care in the world to support their families, to sort of tell them that their child has something that may or may not be a problem, but they have it. That really strikes me as a nightmare. So, and it's going to take a lot. It's one of the reasons you have to have a human in the loop, because I can tell you a chat can't do that.